Hello and welcome to Rajya Sabha Television. You're watching The Big Picture with me, Frank Pereira. With 17% of the world's population, the Indian insurance market accounts for less than 1.5% of the world's total insurance premium, as India is both under-penetrated and inadequately penetrated. India's insurance penetration rate in FY16 stood at 3.42%, far below the global average of 6.2%, according to an industry report. The total expenditure on healthcare as percentage of GDP is just 4%, while in the US it is 17%. According to World Health Organization data for countries performing best in the healthcare sector, the US ranks 37, while India stands at 112th. In India, over 65% of the country's healthcare spending in the years from 1995 through 2014 came out of personal budgets. In China, by contrast, out-of-pocket expenditures ran less than 35%. On this edition of The Big Picture, we will analyze the state of health insurance in the country and the way forward. Joining me on the program today are Alok Saxena, Joint Secretary, Ministry of Health and Family Welfare; Professor Santosh Kumar Mehrotra, Center for Informal Sector and Labour Studies, JNU, will join us on the program as well; Dhruv Sarin, Business Head, Health Insurance PolicyBazaar; K. Badrinath, Policy Editor of the Financial Chronicle; and Rajendra Kumar, Regional Manager, Health Insurance, LIC of India, Northern Zone. Thank you to all my guests for joining me on this edition of The Big Picture. Alok Saxena, I'd like to begin with you, of course. Let's find out and let's put into perspective, what is the health or what is the state of the health insurance sector in this country?
See, as far as I am concerned, from the health ministry point of view, the oldest health assurance scheme in the government is the central government health scheme, which is run on a trust model. Apart from that, the Labour Ministry has the ESIC, Employment States Insurance Corporation. So, for more than 50 years, government has been looking after the healthcare needs of its employees and the labor through a trust model where they don't have to actually spend out of pocket. But that was about all, barring some stray attempts made. Till 2008, it was greenfield. Then in 2008, the RSBY was started. It was a scheme which is pan-India, but the target was the unorganized labor. So it was not a health insurance in the universal sense, but a targeted insurance for unorganized sector labor, your vegetable seller, your thela walas, and the domestic servants.
Sure.
So for them, and it provided a modest cover of rupees 30,000 to up to 5 members of a family on floater basis. And at its peak in the year 12-13, it was operational in 26 states and covered almost 4 crore beneficiaries. But what the importance of RSBY from health insurance perspective by the tax-paid health insurance was that it showed a model to the states and it enthused them into exploring this area.
Sure.
So as a result, while RSBY now is on its way out, and as you know that NHPS, the government is inaugurating very shortly, where the cover is 5 lakh rupees.
Ayushman Bharat, that is, as it is popularly known as, yes.
Yeah.
As the media has termed it, yes.
As media has termed it. Where a cover of up to 5 lakh for secondary.
Sure. So what you're suggesting is the government has been doing its part, and from time to time there have been new schemes to try and cater to the needs of the people.
But the most exciting piece in this was between RSBY and NHPS is that 24 states today run their own, some as top up to RSBY and some their own schemes, their own health insurance schemes of varying sized cover.
All right. Let me bring in K. Badrinath into the picture now and find out, but is this penetration really enough? A population of 1.3 billion, about, 17% coming under, this kind of a scheme. So, is the penetration really enough?
Perhaps we are one country which is most, undercovered in terms of health insurance, and most, despite all the schemes that Alokji has, tried, for some reason it has not reached the people. And one is that. One part is that, the length and breadth or the depth of the insurance that we could have got as even before the private companies came into the sector. Second is, even after the private companies came into the existence, or when the health insurance sector was opened up in a big way, all that, even then, your penetration is very limited. One, it's pocket based, very concentrated, and wherever you are able to make money, then you provide insurance, otherwise you don't provide insurance. Simple.
So the rural sector basically is not lucrative enough for the private companies, is what you're suggesting, and that's why they're staying out of that market.
Well, it's not that rural insurance cannot be lucrative if there is the support of the government, either the state or the center. The point here is that implementation is the biggest issue.
Sure.
We are not able to reach out to the right kind of people in a full way, though the intention is right. There are a lot of good schemes that are available, and now the latest one is Ayushman Bharat.
Sure. Let me bring in Dhruv Sarin into the picture, and try and understand from, from the private player's point of view, what really is holding you back.
See, to be honest, there's nothing as such which is holding us back. I think if I talk about from a penetration perspective, today almost about 28 to 30% of our country has some form of insurance. 18 to 20% is covered by RSBY. About 4 to 5% is covered by government schemes like CGHS, VHS, and about 4 to 5% is where people pay from their own pocket. Right? Today, if you look at largely, the private players operate in the 4 to 5%. The PSU players operate in the 18 to 20% as well as in the 4 to 5%. Now, what basically stops the private players from operating in the even in a from a larger gain perspective from in the 18 to 20% is actually profitability, right? Somewhere I think the price point that has been kept for RSBY and even the price point that has been kept in the NHPS, somewhere the private players think that it is loss making. So it's not that private players are not there as part of RSBY, but only in specific sectors. I think somewhere it has to make sense. The private players, ultimately they are responsible, they are answerable to their stakeholders, right? They can operate at a loss ratio of 100, 105, 110 at max, right? They can't operate at a loss ratio of more than that. So somewhere it has to be a right price point for the private players to get in. I think what the private players can add value is in terms of technology, technology as well as distribution.
How do we strike a balance there?
See, somewhere it has to be, the whole process of distribution and claims has to be more tech driven for, for the right margins to be made by these insurance companies. If I give you a similar example of crop insurance, right? So the government introduced the concept of crop insurance about 3 years back, and the private players are aggressively participating in that because somewhere it's making sense for them. It's a very low. There's not much which a farmer pays from his own pocket, mostly funded by the central as well as state governments. But private players are participating in that, and it is not loss making to them. They are able to make a 0.5% margin, which is good for them. I think something similar has to be done on the health insurance in the NHPS piece, where the cost of distribution and the cost of claims has to be such that even if they get a 0.5% margin, that's good enough.
Sure. Okay.
I think tech plays a very critical role.
Okay,
there.
let me bring in Rajendra Kumar into the picture. Now, what is the attitude of the people, the common man, towards health insurance?
Actually, attitude of common man and people, that is not so much enthusiastic. They are not so, you can say, they are not in position to take. Ultimately, we have to go there and we have to sell the.
Okay. So is there enough awareness, Alok Saxena, as far as the common man is concerned about health insurance, about the health needs, what he actually has to go out and do, what needs to be done? Is that kind of messaging actually happening on the ground?
See, where it is a enrollment-driven process, enrollments are required, on the government sphere. But the new NHPS, what we are looking at is those who will be covered by this scheme, they'll have an entitlement. So which will mean that we have to tell them, and we have to aggressively create awareness, do IEC activities, so that they are aware that they are entitled to these services. And then hospitals have to be accessible. In our NHPS model, we are keeping a big role for government healthcare providers also, as well as the private sector. And the states would have the freedom to run either through on the health insurance through the insurance companies route or through a trust. Because some states, particularly in the south, have done a very good, provided very good services on the trust model. In the end, what we are interested is that people have access to healthcare which is near, accessible to them, close, and the entire gamut of diseases that particularly at most secondary and some tertiary we are able to cover.
Sure.
But primary care will still remain with the government under the scheme.
K. Badrinath, is universal insurance, the answer to our healthcare problem, or should we, further strengthen our public sector hospitals?
See, there are different models, as Alokji was saying. One is you have a model in Tamil Nadu, which has been successfully done, wherein a lot of healthcare insurance has been taken care of by the state-run hospitals. And if you see the Madras General Hospital, it will beat any of the private hospitals in the country and the world. The best of the healthcare because of the insurance coverage that you have given. It has been started by, if you recall, the late Jayalalitha. The AIDMK government started this, and slowly they started increasing the coverage, and also the spread also increased. Because of that, the healthcare number one and the coverage, both of them increased. At the same time, the costs have been kept at a very judicious level. But here, when it comes to the national level, you have twofold problems. One, you have, as we were just discussing, there are only 3 or 4 big players in the healthcare business. And already they are found wanting in a big way in terms of their practices. You've just seen one of the Fortis cases where you have charged 14 lakh rupees for a dengue patient. And there is another case where the 2 kids were born, twins, both of them were packed away thinking that both of them are dead. So one is the practices and ethical part of it. Second is the commercial part of it. Third is the insurance coverage and how the interface between the private healthcare industry as well as the private insurance players and the government schemes gel well. There are too many variables in terms of managing it. I guess even the government should be just preparing itself to see what it is going to get into, perhaps in terms of the new scheme that the finance minister has announced as part of the budget. But it's very ambitious and it's doable. It's not that it is come from...
Sure.
But this kind of a scheme has had a backlash in terms of back in US. If you compare the Modi Care plan that we are talking about and the Obama Care, there the insurance companies and private health players are the biggest beneficiaries. Henceforth, there is a review there.
All right. Talking about penetration, Dhruv Sarin, is cost a big factor when someone considers health insurance?
See, definitely. See, today, if you look at the younger population is not buying health insurance because they don't see value in it. They think they are fit and fine. And when you look at the whole fundamental of insurance, it's a pool where people put in money and whoever claim take a money out of that pool, right? So if the pool is constituted not of younger who do not fall sick, but of slightly older generation, right? The cost of maintaining that pool is high. And hence, for people who are in dire need of health insurance, especially above 45-50, they have to pay higher premiums. So affordability there becomes a challenge, right? So it's like a chicken and egg story. The younger population who's fit and fine is not buying. The older one wants to buy but have to pay higher premiums and hence are not buying, right? So somewhere I would keep it on insurance companies and say that it's their prerogative to create products and solutions in such a way that even a 25-30-year-old starts buying and he sees value in paying a premium so that it can also be subsidized for the senior citizens.
Sure. Let me bring in Professor Santosh Kumar Mehrotra of JNU now into the picture, who joins us on the program. Welcome, Professor, and thank you for joining us on the program. We're talking about the affordability of health insurance. How do we ensure that we make it affordable so that the masses can be covered?
Well, as far as the NHPS as currently articulated is concerned, the person who is covered is not going to have to pay. The entire cost, as with the RSBY, is going to be met by the central government and the state government 60-40. So where is the question of, affordability? The real issue is there affordability for the government? And Honestly,
you know, Professor, I think we'll get
I think
into
we
the
have to
affordability
look
of the
at
government a little later on, because we're not talking about that particular scheme, the Ayushman Bharat scheme at the moment. We're talking about the state of the health insurance sector as a whole in this country. How do we ensure that 1.3 billion people, how do we ensure more penetration of health insurance in this country?
Okay. Thank you very much for clarifying that. I don't believe that health insurance is the way to cover 1.3 billion people with health services. In a country which is relatively poor, it will take us a few decades before the entire population is covered, and I don't think we can afford to wait, because our demographic dividend is around for only 20 more years. And an insurance model, unfortunately, has, even in the rich countries, works only when you have the capacity to regulate. In our country, when you're talking about RSBY, so RSBY, for instance, in a state normally has no more than 5 to 10 people in the state capital managing the RSBY. How do you expect to regulate in a state as the size of UP or Bihar with 10 or 15 people at most? I mean, so you don't even have the capacity within RSBY to manage RSBY, and now an RSBY's coverage is much smaller than what we are going to go with. So point is, in countries which have managed to improve their health outcomes quickly, they have increased public expenditure and they have built up a functional 3 or 4 tier health system, which is largely government funded. Because even with this model that is being proposed, the NHPS or the RSBY, ultimately the money is going to come from the government. If the money is going to come from the government, why are you going to finance private providers? And when the government providers' capacity to respond to the increased demand that will happen as a result of the insurance increase is limited.
Okay.
The infrastructure in the public sector is limited. Money is limited. The human resources are limited because money is limited. And the government is prepared to spend 1.15% of GDP only. And
Okay.
I'm
going to take the point that you're making.
National health
I'm going to take the point that you're making to K. Badrinath now. As far as the professor says the insurance model is not going to work. We need to ensure that we enhance our public sector to treat several of these patients who go to hospitals.
So my guess is that everything cannot be done by either the state government or the central government. World, if you see Japan, the biggest insurance companies are owned by the cooperatives, life as well as non-life. If that is the case, and there are companies where private players also have a role there. It is not that everything should be funded by the central government or the state government. And then the penetration will be limited, like you are seeing right now. Whatever may be the effort. He is right in a way when he says that, you don't have that kind of resources to cover the entire population. But my guess is there should be a multi-pronged approach. There should be, both the state-owned companies, the private companies, and the public sector, the joint ventures and the cooperative insurance companies, which can do it. And only thing is the modeling part is there are different models. So these models need to be weighed across, and whatever is, like you were saying.
I'm coming to you, Professor. I'm coming to you. Let him complete his point.
There is a flexibility that must be given to the states to decide as to what should be the way to implement these programs.
Sure. Let me bring in Rajendra Kumar, who's been patiently listening to all of us over the last 10 minutes or so, because everyone's been making, their own point. As far as penetration is concerned, Rajendra Kumar, it's at 4% at the moment. There is tremendous potential. There is tremendous scope there. What is the potential for insurance companies going forward?
Potential is huge, no doubt. But we have to create awareness and other drives to be there. Since potential, as you have mentioned that nearly 20%, in developed countries there is 20%, and we are very, we can say it is, we have negligible penetration. So awareness, other drives, as
Sure. So the penetration is low, so there is tremendous scope for insurance companies is what you're suggesting. Professor, I'm going to come back to the point that K. Badrinath was making, that, all stakeholders need to come on board to make the health sector a success, the health sector story a success, and to go forward, of course, everybody needs to be taken into confidence, and only then will we see a changed healthcare system and a changed healthcare sector in this country.
There's no problem with statement in abstract. In theory, that's a very fine statement. And I should tell you that, I do have some experience in this business because I have just been helping for the last 6 months the UP state government arrive at a state health policy. And I was economic advisor for the social sectors for the Planning Commission of India. So I do have some idea, and then I was, senior economic advisor in UNICEF. So I have some idea of what I'm talking about. So with this background, let me say a few things. You see, which insurance are we talking about? Who will buy private company or even government insurance, or are we talking about for the poor? For the poor, which is this NHBS scheme is intended to essentially take to scale the RSBY. Now, let us just look at this insurance-based scheme for the poor. The insurance-based RSBY has its own problems, just as the state-level schemes do, and I will come to each one of them in a minute. So, the RSBY has been evaluated, and the evidence suggests that it has not managed to reduce out-of-pocket expenditures for those who are covered. Why are we surprised? Hospitalizations happen once in a while. Most out-of-pocket expenditures for most people are accounted for by two categories of expenditures: outdoor patient consultations, diagnostics, and medicines.
Sure.
None of this is covered in the NHPS or the RSBY or any of the state governments.
Okay, point taken.
So, what is the objective?
I'm going to get Mr. Alok
being...
Saxena to respond to what you're suggesting. You're saying that, you heard what the professor said, Alok Saxena. You're saying that, you need to strengthen your public healthcare sector at the grassroots. Only then can you talk about any of these mega schemes, is what he's suggesting.
Nobody can agree more with that. But you see, NHPS is, as you introduced, is part of the Ayushman Bharat. And Ayushman Bharat is standing on primary care through 155,000 health and wellness centers for a population of 5,000 each, where the emphasis will be on the same things which the professor is saying, on diagnostic, on first contact with the healthcare provider. Also, they'll act as referrals. So it's not that it's a piece in isolation. He said RSBY has been evaluated. Yes, it's been evaluated. And this is the result.
Okay.
NHPS is the result.
Fantastic. So great things to come as far as the healthcare sector and health sector is what you're suggesting. Very quick closing comments from both my panelists here. India compares very poorly, Dhruv Sarin, when compared to other countries as far as health insurance is concerned. How do we change that?
See, I think, as the other panelists have said, I think NHPS is a great scheme. I think the 150,000 wellness centers, that will take care of the primary care. NHPS will primarily take care of the tertiary care and to some extent secondary care. More secondary, some bit of tertiary, I would say. I think implementation is a big key. Getting the healthcare providers and to the extent of not just the hospitals but even the manufacturers of equipments as well as drug makers into the whole scheme, and kind of getting good rates or discounted rates, so to say, from them. I think getting all stakeholders together in the entire ecosystem, I think that will be a big challenge.
Okay,
but if you're able to implement, I think it will be a great success.
But now close the show for us with the way forward.
See, two issues. It's a very ambitious scheme that the finance minister has announced. Two issues need to be give enough flexibility to the implementing states, number one. Secondly, if they want to dovetail the central scheme with the state schemes already that are there, it should be allowed. Third is the big point there will be that how the private companies will not misuse this to profiteer.
Okay.
This
All
is a big issue.
All right. On that note, then we'll call it a wrap on this edition of The Big Picture. I'd like to thank all my guests for joining me on the program and putting things into perspective for us. That's it from me. See you again next time.